that is close to our hearts. Now, let's proceed. So maybe in the chat box, please type your name, also where you're from. Yeah. So we also have participants or participants coming from Baguio, from Davao. Wow. Okay. All over the country then. Okay. So proceed. So yes, we are from the management, Masters in Development Management, and I am with Carlo and Miles, and we are students of Masters Development Management, but we focus on impact first investing. And the impact first investing allowed us to really understand what are really the opportunities for us to invest, but or to help social enterprises, but also to look at what should be the priorities in terms of investment. Now, because of the alarming trend based on the data of UP Diliman, wherein 20% of Filipino youth age 15 to 24 contemplated suicide in 2021. So this was ito mga data na to ay galing sa published also in newspapers, in the media. Then the suicidal ideation grew from 3% in 2013 to 7.5% in 2021. So it's very alarming that more people are thinking about committing suicide. And then 60% did not help, or only 10% or 1 in 10 students were aware of prevention programs. So using the impact first investing approach, we also did a study. So we can the impact first investing, or by definition, is making investments with the intention to generate positive, measurable social and environmental impact alongside a financial return. And this is really to address also the United Nations Sustainable Development Goals, wherein we are trying to address SDG number 3, or the health and well-being, promotion of mental health and well-being. And also with an interplay with SDG 4, wherein quality education and relationship between mental health and optimal learning outcomes. So there is a connection between mental health and also the performance in schools. Now, we discovered also during our project that we went to Camarines Sur National High School, the largest high school in the Bicol region, wherein we discovered through the FGD with students from all grade levels, and also teachers and guidance counselors, wherein the pandemic really had the impact on the mental health or well-being of our students, and also even our teachers. Then there's also the mentality or the negative perception against guidance counseling. Then also, as an educator constraint, there is also limited personal interaction time, given that the number of students, the ratio of a guidance counselor to a student is usually 1:1,000 to 5,000 to 2,000, etc. So also we discovered that there is a need for training in terms of practical training and how do we really address mental health issues in the classroom. Now, also, lastly, look at the tools that are being used by guidance counselors and also in schools, wherein there are concerns about the heads and the psych first aids efficacy. All right, next. Coming up with this, or with these findings, we discovered that maybe we can look at the problem and look at maybe there is an insufficient early identification and response to learners' mental health needs. And our goal is really to strengthen early detection and active support for learners' mental health. And maybe through the school-based intervention, maybe we need to strengthen the school-based intervention and prioritize evidence-based mental health programs. Also, we have to, aside from the school setting, we need to encourage or engage more of the family and the community. So because when we also found out in our research that there are students who are really afraid to tell their parents, even their classmates, about their mental health situation, or are they sure that what are they feeling also, or is it really a mental health concern? So our target, or maybe that's why we developed this framework, wherein we look at it's called Safe Mind conceptual framework, wherein we look at the screening part, when there is a proactive surveillance with sustainable impact. So there is a need to prioritize investments for early detection so that we can reduce long-term societal and economic implications. Also, second one is the A, the ACT. So immediate response with measurable outcomes. Wherein we have to channel resources to produce tangible, positive changes for individuals and the community. The third one, the F, so SAFE. F is facilitate referral, wherein we have to streamline support systems with scalable solutions and also build an expansive network of mental health experts, ensuring timely and quality care. And lastly, for the SAFE framework, we have to educate or really empower awareness with the long-term return of investment, wherein we have to invest in evidence-based school programs for long-term societal benefits and stigmatize mental health for a cohesive community. So this is the SAFE framework that we have developed coming from the research that we conducted and also the several consultations that we did from different experts in the mental health field, in the school-based setting, and also in the academia. So now I'll turn over the floor to Doc Carlo. We hope that in this forum that you will open yourself into learning more about the situation in the mental health as field and also the impact of this in the education sector, as well as to how we can make an action after this. Doc Carlo?
Okay, good afternoon, everybody. So efforts have been made by different sectors to address the mental health issues, but sustaining the initiatives is challenging due to the growing number of adolescents with mental health problems and the need for additional resources. The Safe Mind framework offers a comprehensive approach for additional resources. A comprehensive approach that addresses the critical need for screening and timely referral while striving to bridge the existing gap in the availability of mental health professionals within the basic education sector. This forum aims to foster discussion on how stakeholders like professional organizations, advocacy groups, and impact investors can collaborate to tackle these challenges and provide equitable mental health services to students. Inputs from the panelists and participants is vital to understanding the sector-specific issues and finding ways for impact investors to support sustainable mental health programs. The goal is to encourage collaboration at the intersection of these different mental health initiatives. So to introduce our keynote speaker, our keynote speaker is the Medical Center Chief of the National Center for Mental Health. He received his Bachelor of Science in Medical Technology from the University of Santo Tomas and his medical degree from the De La Salle University. He finished his residency training in psychiatry at the National Center for Mental Health. He is a diplomate of the Philippine Board of Psychiatry and a fellow of the Philippine Psychiatric Association. He became a supervising psychiatrist and was the head of the psychiatric emergency room, the outpatient department, and the detoxification unit. He was also a regular speaker of the Department of Health, Department of Education, and Department of Labor. In 2018, he became a member of the Task Force for the Development of the Implementing Rules and Regulation of the Mental Health Act of 2019. During the time when he was the chief of the Medical Professional Services for the community, he completed his Master's in Management major in Hospital Administration and was appointed as the Medical Center Chief in January of 2021. Let us all welcome Dr. Noel V. Reyes for his keynote address. Kaya sir. Lalapit lang po natin
Okay.
ng mic.
Sige. Thank you, Apons. Right. Good afternoon. To the distinguished panelists, good afternoon po. Yung mga nandito po, magandang hapon. At yung mga joining us through the online. Good afternoon. Now, before anything else, now allow me to express, of course, my utmost appreciation to the organizers for, of course, inviting me to talk to you this afternoon. No, it is indeed timely. Well, in fact, in my opinion, no, the issue at hand is bordering already with urgency. That we have to come up with sustainable mental health programs. As we move through the third year of the COVID-19 pandemic and increasingly come face to face with the health impacts of climate change, the need for more capital directed at improving health and well-being is apparent. Some of this capital will come from government, some will come from multilateral organizations, some from philanthropy. But as you all know, this is not enough. Impact investing would probably be the golden thread that can weave through the fabric of sustainable healthcare, patching the gaps left by traditional funding mechanisms. It's an investment strategy that aims to generate specific, beneficial social and environmental effects in addition to financial gains. This approach is particularly potent in the healthcare sector, where the need for innovative solutions for identified gaps in the health service delivery. One insurance company has analyzed the current gaps over the past several years, indicating the growing opportunity for investing in this sector, the healthcare, is a must already. But before delving into the opportunities that lie in the impact investing, let's paint a picture of the current scenario. Next slide, please. Our world wasn't set up to respond to mental health needs before COVID-19, and it certainly isn't now. It is estimated that there's 284 million and 265 million suffering from anxiety and depression, respectively. No? As mentioned by the introduction, suicide is the second leading cause of death among 15 to 29 years old globally. Yet only 2% of the health budgets are spent on mental health. No? These alarming statistics show that there's a crisis of inaction in terms of mental health all over the world. Next slide. We can see that here in our country, the government total expenditure to address mental health issues is at 0.22% in 2017. Next, with an allocated a mere 12.19 pesos per Filipino. Even the workforce, next slide, is reflective of the efforts being laid to address the situation. Can you imagine? There's 0.633 psychiatrists for every 1,000 Filipinos. There seems to be a lack of awareness, and in spite of numerous programs for advocacy and promotion, stigma is still being manifested towards mental health. Allow me to brief you on the government's action agenda for health. Next slide. I will emphasize on action agenda number 6 and number 8 as I feel that it is relevant to this afternoon's topic. The 8-point health action agenda is a medium-term strategy for the health sector for 2023 to 2028, the term of PBB. It is crafted to answer the health challenges of our current times, built on the foundation of reforms before us, and in response to the call of the President and the administration's priorities. The agenda places the recipients of healthcare and services, bawat Pilipino, bawat komunidad, bawat health worker at institution, central to all the undertakings and interventions. It will therefore focus the actions with the end in mind and at all times, and to hasten the realization of the vision of Filipinos are among the healthiest people in Asia by 2040. Next slide, please. The number 6 agenda is enhance Filipinos' well-being and ensure quality mental health services. Next slide. This entails establishment of a mental health program, that is accessible for every Filipino as part of the primary care services of each locality and primary care provider. It also entails integration of gender considerations in the health facilities and services, promotion and imbibement of Filipino art and culture in the health facilities, and of course, mainstreaming of the use of traditional and complementary medicine in the health system. Action agenda number 8, next slide, is to strengthen health systems to prevent, to manage, and to recover from outbreaks and pandemics. Next slide. This entails strengthening of existing disease surveillances and epidemic response procedures. Now, much have been said about the next pandemic. Next slide, please. And it is the reason why I included number 8. Numerous articles, next. Numerous articles and researchers have pointed out that truly mental health issue will be the next pandemic. Next slide, please. Since 1990, mental disorders have increased globally by 40 to 45%. Why is there a rise in mental health disorders? Beside the direct health and social impact of the individuals, this increase in mental health disorders, as pointed out earlier, is costing the Philippine economy 68.9 billion pesos per year. Next slide. The National Center for Mental Health 24/7 Crisis Hotline points to the same trend. Of course, COVID-19 happened, but upon careful analysis, majority of the reasons for calling is already beyond COVID-19. Over the past 4 years, the number of calls quadrupled. The red line is the total number of calls. The yellow is the suicide-related calls. For 2023, that is only up to August. So, medyo tataas pa as the year ends. No? So, if we analyze the age distribution of the callers, next slide, this result will be almost the same as other related literature on the onset of mental illness. One study pointed out that 44% of high school students reportedly being persistently sad and hopeless. Within 1 decade, suicide rates have tripled in the 10 to 24-year-olds. Could just imagine when I was 10 years old, suicide was never in my mind. No? But right now, our children now are thinking. No? Same. Next slide. And as a known fact is that 50% of all lifetime mental illness starts by age 14. 75% by age 25. This means that mental health can no longer be treated as an individualized problem, but rather as a widespread public health issue. Before we can arrive at a definitive answer on why there is such a rise in mental health issue in the past decade, we have to review and understand the causes of these disorders. Mental health disorders are incredibly complex, and there are many variations and combinations of factors that lead to these disorders. Next slide. They can range from biological factors to external social and environmental factors. Biological factors include genetics, chemical imbalances, and physical injury. For example, studies have shown that disorders like bipolar, depression, schizophrenia have genetic roots which can get passed down in the family. More external are the direct psychological factors tied to an individual's personal experience, the cognitive and affective traits like coping mechanism, coping skills, self-esteem, memory, and of course trauma. Poor self-esteem, for example, have shown to play a critical role in the development of depression, anxiety, and substance abuse. Next slide. Even further out are the social and environmental factors such as discrimination, poverty, pollution, displacement, food insecurity, etc. They can all have detrimental mental health impacts on a larger scale. For example, a study showed that people exposed to armed conflict, where they experience constant stress and trauma, are more vulnerable to develop a mental disorder. Next slide. Some of these external factors can also interact with certain internal factors and put people at higher risk. For example, internal factors like age, gender, and race can interact with social factors like discrimination and poverty to increase the risk of developing mental problems. So now that we know the causes of mental disorders, which of these factors is behind the recent increase of mental disorders in the last 20, 30 years? Some biological factors like genetics and physical injury remain constant, so they can be ruled out. Next slide. But as we move towards the more external social and environmental factors, we see that there has been a lot of change in the past decade. These changes have played significant role in the increase of mental health issues today. Allow me to explore 4 areas of these social and environmental factors. Next slide. Right. Back. Yeah. Inequality. Over the years, next slide, the gap between the income of the top 10% and the bottom 50% of the country has almost doubled. This unequal distribution of income means that despite economic growth, many people still face financial problems. This economic distress can adversely impact people's mental health as they promote fear, worry, and hopelessness, and a sense of powerlessness to exert control over their situation. Next, global warming. In 2021, the IPCC, the Intergovernment Panel for Climate Change, their reports warns us that the global warming and extreme weather conditions like heat waves, floods would become more frequent and more intense. The direct contact with these extreme weather conditions can disrupt people's lives and lead to trauma, loss of resources, and social support. They are now at risk of developing mental disorders that in one study, they analyzed the mental health of flood victims, and they found out that 20% have been diagnosed with depression, 28% with anxiety, and 36% with PTSD. Next slide. We evolved as social creatures, strongly dependent on familial and social bonds. However, today many people live alone, far away from their communities. A major reason for this would be a better job opportunity, quality education, and of course, advanced healthcare offered in cities. Due to these incentives, in 2020, 58.93 million or 54% of the total 109 million population of the Philippines lived in urban cities. This represents an increase of 7.2 million persons from the 51.73 million urban residents in 2015. So in 5-year time, people migrated into the urban cities accounts for around 7 million. Now, cities are expensive and have limited space. This often results in many people moving to cities alone, leaving their families and support system or support networks behind. Social media. Today, almost 1 in 3 people around the world use social media platforms. Here in the Philippines, the report published by the Digital Philippines in 2023, early this year, January, I think, states that 73.5% of the population, or 84.45 million Filipinos, are social media users. This technology has a direct link to people's lives and their social connections and interactions. Many researchers highlighted that social media is heavily linked to negative well-being and low self-esteem, especially among young people. A 2017 study found out that people who use 7 or more platforms, is there such a person who uses 7 or more platforms, no, were 3 times more likely to have high levels of anxiety than those who use 0 to 2 platforms. No? No? Bilangin nga natin yung platforms, ang dami ba? Alright? So, some researchers have also concluded that spending more time on social media can make people experience social isolation. No? Masyado ng maraming memes nga sa Facebook. No? One family eating together. Pero lahat nasa cellphone. They're not talking. No? So, for what is eating dinner together if you're not talking? Right? Next slide. These social and environmental factors are creating mental health challenges. So it is very plausible that the recent increase in global mental health problems is correlated to these large-scale social and environmental changes. If it is the case, solutions to this public health crisis, in addition to the conventional treatment and prevention measures, needs to address these factors. And since these factors will continue to intensify in the future, there is an urgent need for more sustainable programs and services, more research, more policy and awareness campaigns about the increasing mental health crisis and its impact to people and communities around the world. Here are examples of what is being done elsewhere. Next slide. In Belize, they have the HAT initiative, Helping Adolescents Thrive, focuses on reduction of self-harm and substance abuse in adolescents. In Jordan, the EASE program, the Early Adolescent Skills for Emotion, which is a brief group psychological intervention for 10 to 14-year-old experiencing high distress. Cape Town in South Africa, the STARS Project, Sustainable Technology for Adolescents to Reduce Stress. A digitally delivered psychological intervention via chat box for 15 to 18 adolescents experiencing high distress. So this, from local community-based programs implementation to integrated strategies and all of society's approaches. So investing in mental health is not just the right thing to do. As experts have proven time and time again, it is also good for business. Businesses have the power to create real change through tackling workplace mental health and engaging in the global conversion around mental health in the workplace and beyond. On one study in the US, they found out that for every $1 invested in scaling up treatment for depression and anxiety, it leads to a return of $4 in better health and ability to work. So, reiterating the essence of impact-first investing, which is the shifting from do no harm to intentionally do good. In the long run, this will all benefit our young people of today, our future adults. Thank you.
Thank you very much, Doc Noel, for that insightful message, insightful and comprehensive message on the state of mental health in our country, and as well as the need for impact-first investors to actually be of help in our efforts to sustain and scale the services that we provide for our in the basic education sector, not just in the basic education sector, but in the whole country as well. So, to streamline our agenda and make most of our time, We will begin by allowing each panelist to present their respective topics individually. Following these presentations, we will transition to the panel discussion phase. So for our first panelist, he is a fellow of the Philippine Psychiatric Association. He finished his medical degree at the Pamantasan ng Lungsod ng Maynila and his master's in public management, major in health systems and development from the Development Academy of the Philippines. He took his residency training in psychiatry at the National Center for Mental Health. With 12 years of government service, Dr. Boncajes has served both as a public servant and a psychiatrist. He is a respected subject matter expert on mental health and represented NCMH in various public forums. Currently, he leads the Office of the Special Concerns Unit, overseeing programs such as community-based capacity building and training, the NCMH Crisis Hotline, the Center for Wellness, the Mental Health Information System, and the Research Unit. His steady leadership is integral to the daily operations and growth of these units. He is also a member of the therapeutic community of NCMH and part of the technical working group of the Philippine Council for Mental Health and part of the development framework and plan for selective specialty centers for mental health of the Department of Health. Let us welcome Dr. Rodney Boncajes, who will discuss the challenges of community-based mental health programs. Okay, we are having some technical difficulties. Alam mo, technology can be technology can be a friend, sometimes a foe. Okay, there we go. Thank you, Makoy.
Isang malusog na hapon po sa inyong lahat, and thank you for the invitation to discuss the challenges of community-based mental health programs experienced by the NCMH or the National Center for Mental Health. Dr. Belmonte or Dr. Apons for us is also or has been also a part of our Office for the Special Concern and has been also an instrumental in the development of our policies and guidelines, especially in the Center for Wellness of our Office of the Special Concern. So he left us, kailan nga ba, Apons? 2 years ago to pursue his career in AIM and as well as his private practice. So good afternoon. Okay. So the community-based mental health programs stem up from the enactment of the mental health law with the primary purpose of enhancing the delivery of integrated mental health services and promoting mental health and protecting the rights of persons utilizing psychiatric, neurologic, psychosocial health services, and primarily aims to value, promote, and protect mental health, provide timely, affordable, high quality, and culturally appropriate mental health care services, and aims that mental health conditions are treated and prevented and are free from discrimination and stigmatization. So the burden, or to have a context of what is the burden of mental health conditions in the Philippines, based from the Global Burden of Disease Collaborative Network in 2020, the burden of mental health conditions in the Philippines as per 2019 is about there is 1,365 individual per 100,000 population that is affected with mental health condition. So the burden of mental health condition is measured in DALYs, or disability adjusted life years. The DALYs is the year or the sum of years of life lost due to premature mortality and the years lived with disability because of a specific condition. So in this case, mental health conditions. So the deaths that is associated with mental health condition is around 0.0026 per 100,000 population, with the incidence rate of around 3,411 per 100,000 Filipinos. The top causes of DALYs in the Philippines in 2019 are on the screen, and at the number 8, or ranking at the number 8, is mental health condition. And another one is self-harm or interpersonal violence, which is ranked 10 among the 22 important mental health or important conditions associated with DALYs. Now, for the specific type of mental health conditions, we have on the board, the number 1 is in the Philippines is anxiety disorder, and this is followed by depressive disorder, schizophrenia, other mental health disorders, conduct disorders, bipolar disorder, autism spectrum disorder, intellectual disability, eating disorder, and attention deficit hyperactivity disorder. So as you would take note of, some of these mental health conditions are specifically being or can be diagnosed at an earlier age and even predominant on school age population. Now, when it comes to the distribution per age, among those with mental health conditions of all types, the 45 to 49 years old age group had the highest DALY with around 1,961. And this is followed by the 40 to 44 years old age group with around 1,949.62 per 100,000 population. So where are our school children? Our school children are here from 5 to 19, maybe 19 to 20, or 5 to 14, or 5 to 19. So these are also they are also contributors to this statistics. Now, what can be the challenges in setting up or integrating mental health services at the primary or secondary levels of care? Pre-pandemic, there has been the second regional consultative meeting in the development of guidelines on the integration of mental health in the primary and secondary levels of care for ASEAN member states. And this has been held or was held in Indonesia. And they have identified that among the member or ASEAN member states, these are the common concerns or gap. And these gaps would include health system delivery, that would include stigma, the low mental health literacy of communities, incomprehensiveness in assessing mental health condition, the lack of access for homeless individual, the lack of facilities, the weak referral system, and so on. They have also identified the importance of a gap when it comes to human health workforce, such as the lack of staff, the limited general practitioner and nurses who are providing mental health services, the limited type of mental health workers, and the lack of competencies of non-specialists in identifying and providing early intervention for those individuals manifesting mental health conditions, among others. They have also identified that health system financing can really be problematic among the ASEAN member states. Specifically, this covers health insurance coverage and inadequate budget for mental health programs. There is also a gap when it comes to health information system, such as there is no existing or there are poor existing data collection and monitoring of individuals or number of individuals with mental health conditions. The access to essential medicine plays also a primary role in the integration of services. They have identified that the limited essential medicine in the primary healthcare areas, as well as the limited second generation medicine in the secondary levels of care, and the uneven distribution of essential medicine contribute to the inequality or discrepancy when it comes to mental health services at the community. Leadership and governance also plays important role in the implementation of integration of mental health services, such as some countries in the ASEAN or some ASEAN member states does not or do not have yet mental health act or mental health policy. Fortunately, the Philippines has its own mental health act in 2018, and community empowerment and research development are also among the gaps that have been associated. or have been identified during the conference. Now, Dr. Reyes has presented already the gaps when it comes to financing and mental health workforce. Now, I would like to focus on to the services that are available in the country when it comes to hospital-based or facility-based, specifically for the inpatient care. So at present, we only have one mental hospital, so that's the National Center for Mental Health, but there are other 84 psychiatric units that are attached to a general hospital. There are only 11 inpatient facility specifically providing services for adolescents and children, and one forensic inpatient unit. There are 59 residential care facilities. This is as of 2019. And the Seoul Hospital, the National Center for Mental Health, would have a number of around 3,365 average daily inpatient at any given day in a year. Now, when it comes to outpatient care or outpatient services, there are 85 mental health outpatient facilities attached to a general hospital. 11 outpatient facilities would specifically provide mental health services for adolescents and children, and there is only one mental health daycare or treatment facility, while there are 119 community-based or non-hospital mental health outpatient facilities. With the gaps in the facilities providing mental health services, the Department of Health released the Department Order 2021-001, specifically on the designation of selected DOH hospital as specialty centers for various conditions, including mental health. So posted on the screen are the 19 or the 23 hospitals designated as National Specialty Center, Advanced Comprehensive Centers, and Basic Comprehensive Centers for Mental Health. So as you can see, there are 9 Advanced Comprehensive Centers that will be established in CAR, Region 2, 3, 5, 6, 7, 8, 9, and 11, while the rest of the regions would have their Basic Comprehensive Centers. So this put NCMH, which is at NCR, as the National Specialty Center for Mental Health. However, the implementation of this designated mental health centers will be implemented in in tranches in such a way that the expected full functionality of this health centers or mental health centers will be expected by 2025. Now, going to the community-based mental health programs, there's specific provisions in the Mental Health Act that would support the establishment of community-based mental health care facilities, specifically Section 15 and Section 16, which states that the community or mental health services at the community level should be provided by a responsive primary healthcare service which shall be developed and integrated as part of the basic health services at the appropriate level of care, be it at the municipality, city, or barangay level. Section 16 states that community-based mental health care facilities should be supported by the Department of Health when it comes to fund in establishing and assisting the operation of this community-based mental health care facilities. On the other hand, certain provisions such as Section 25 is focusing on the capacity building, reorientation, and training of those individuals who will man the facility. There's specific provision in Mental Health Act, Section 27, focusing on the capacity building of the barangay healthcare workers, giving emphasis on the importance of their roles in providing community care or mental health care at their specific localities. Now, the same concern or the same gap has been identified when it comes to the implementation of mental or community-based mental health services in the Philippines. This is what I have mentioned earlier. Tornikoff in 2010 proposed the balanced care model approach specifically for low resource setting, and this balanced care model approach for community-based mental health services are focusing on population and public health needs, focusing on case finding and detection of mental health conditions in the community. The model should be locally accessible and should be with community participation and the decision making in planning and provision of mental health care services. and there is a role for those service user and individuals and families of service user, and there should be a mutual assistance or peer group support of service users. So the balanced care model approach also support the idea that the initial treatment should be provided by the primary care or the community staff, and there should be a step care options for referral to specialist staff or hospital beds if needed. So this balanced care model approach should be also backed up by supervision and support from specialists or from mental health professionals, in which case the Philippines has already limited numbers, and should have interface with non-government organizations. And there should be a network at each level, including between different services, the community, the traditional, and the religious healer, giving emphasis on the idea that mental health is a combination or should be framed on a biological, psychological, socio-cultural, and spiritual aspect. Now, what we have done so far in NCMH is to train our primary care providers, our primary care physicians, the public health nurses, and the general practitioners in implementing mental health programs at their community. And this have been done through the implementation of what we call the MH Gap, or the Mental Health Gap Action Program. So this is a WHO program wherein non-specialists are capacitated or trained to identify, manage common mental health conditions with proper, of course, supervision of specialists should the need arise. So as of 2021, this is the national data. There is about 49%, or a total of 1,259 rural health units that have been capacitated with a mental health gap action program. Now, aside from capacitation, is the provision of mental or medicine access program for mental health or psychotropic medication. Because, as mentioned, the program is aiming to train our primary healthcare provider in providing interventions, and one of the interventions is providing the most appropriate medication for the condition. So, along with the training is the provision of free medications for those service users. And as of 2022, there are already 362 medicine access program for mental health access sites, 65 of 147 cities, and 228 of around 1,485 municipalities. And there has been 161,000 service users registered or given free medication through this program. Now, aside from focusing on the integrating community or integrating mental health at the community level, we also have, or the National Center for Mental Health also have this national NCMH crisis hotline together with the Department of Health. The NCMH crisis hotline aims to provide interventions for those individuals who are in crisis through a 24/7 hotline manned by trained responders. And as of September 30, 2023, we have already provided service to 66,000 Filipinos or callers, and made 32,550 referrals to different services such as the emergency rooms, the telemental health consultation, the outpatient services, and external referrals. So NCMH Crisis Hotline is, of course, the primary hotline in the Philippines, but we also recognize that there are other hotlines existing in the country, such as the Tawag Paglaom of Vicente Soto Memorial Medical Center and other NGO-run crisis hotline. Now, along with the capacitation of the advanced comprehensive and basic comprehensive centers for mental health is also the training on establishing their own crisis hotline. So we have this capacity building on basic crisis hotline management. And so far, we have already covered 3 advanced comprehensive centers for mental health and 4 regional offices of the Department of Health. We also focus not only on the interventions when it comes to suicide prevention and integration of mental health services at the community, but we are also focusing on the readiness of the individuals in responding to disasters and to emergencies. Our Center for Wellness has also been contributory to the 5,000 people having trained with mental health psychosocial support or MHPSS. Okay. So, what can be or what have been the key requirements for a somehow successful community-based mental health program? So, we have identified the following as key factors in having yeah, a good community-based mental health program. One is the careful preliminary situational analysis or needs assessment. We recognize that each community would have different needs, and this can be influenced by their current status, the strengths of the levels of cares that they have, their existing health system, and the community context. We also recognize that there's a need to build on existing networks or structures and human resources because we have limited numbers of specialists at the moment, and we also have limited numbers of fund to hire new people. So we need to build on the existing human resources. Funding can be very, very challenging, but there's really a need to shift or redistribute the funds from maybe tertiary to secondary and primary levels of care, or at the most is make new funds available. There should be clear delineation of mental health conditions or disorders because non-specialists can only identify few targeted mental health conditions that can be treated at the primary care level, and this should be supported with simplified requirements for providing psychotropic medications and, of course, capacity building for them to be more proficient and skilled in providing the services. Human resources and training competencies, of course, uninterrupted supplies of medication, supervision and support of primary healthcare staff, uh, intersectoral approach and link with community services, both formal and informal. And lastly is an efficient way of recording, reporting, and evaluating and monitoring the efficiency and effectiveness of the community-based mental health program. Okay? So to wrap up, mental health workers and professionals can be instrumental in fostering comprehensive, individual-focused mental health approach in various settings, be it at the community, at the school, or the workplace, by providing their expertise, support, and collaboration, thereby helping to create a more mentally healthy and supportive environment for everyone. So by providing leadership and expertise in these areas, our mental health workers and professionals can help ensure that setting-based mental health programs are grounded in scientific knowledge, effective in promoting positive outcomes for everyone, and responsive to unique challenges within the different settings or environment. So maraming salamat po.
Hello, hello. Yeah. Thank you, Doc Rodney, for that insightful discussion on the challenges of community-based mental health programs. No, for our second panelist, she is a multifaceted professional with an extensive background in education, psychology, and counseling. She served as the Vice President for Academic Affairs at the Philippine Normal University and held various leadership positions within the university, including the Dean of College of Arts and Sciences. Dr. Hines is a registered guidance counselor and psychologist, contributing significantly to the field through her involvement with CHED technical committees as a PRC CPD council member. Beyond her educational roles, Dr. Hines is a prolific writer of textbooks, a project manager, and a sought-after speaker. She has a rich history of leadership in professional organizations, having held positions like the National Executive Vice President for State Universities and Colleges for Teachers Education Association and the founding president of the Philippine Association of Psychosocial Helping Professionals. She has also played vital roles in the Philippine Guidance Counseling Association. Dr. Hines holds a PhD in psychology from the University of Santo Tomas, an MA from the University of the Philippines, Diliman. She has further honed her expertise through postdoctoral training fellowships in various institutions, including those in Amsterdam and Germany. Additionally, she is a certified trainer in clinical counseling supervision, awarded by the Australian Counseling Association. Let us welcome Dr. Adelaida Hines, who will discuss the challenges of mental health professionals in the basic education sector. Additionally, Dr. Hines is one of those people who played a pivotal role when we developed the uh, partnership for the teleconsultation program of the NCMH Crisis Hotline during the height of the pandemic. So it was through their help that we were able to develop such an endeavor. And I do extend my warmest, sincerest gratitude for the partnership that we had when I was still NCMH Crisis Hotline. Dr. Hines, you may have now the floor.
Maraming salamat po, Dr. Pons Abelmonte. And I'm very much honored to be here with you. In front of me are all specialists, no, in the field of mental health, because you are all mental health professionals. Okay? So I was given the task to give the challenges of mental health professionals in basic education specifically. So it is therefore in this context that I have yet to operationally define what a mental health professional, no, is all about, no? Because for others, they would find mental health professional as exactly the same as a helping professional. In which case, according to RA 11036, there are just 5 groups of people who should be considered as mental health professionals. And that is in the definition of terms, section 4 of our law, 11036, and specifically articulated in the IRR, implementing rules and regulations of the same law. So anyway, what would be the people or a group of people included as mental health professionals? Of course, the first is the medical practitioners, medical doctors, no? And included to that would be the psychiatrists, be it adolescent or child psychiatrists. And then the next one are the psychologists, the social workers, the nurses, and then, of course, the guidance counselors, and any other professionals who have been trained in mental health, no, activities. So that's the definition of mental health professionals, no, according to our law, 2018. No? So what about the challenges, no, of the mental health professionals in basic education? So we have to be aware that in basic education or in the school setting for that matter, the guidance counselors are the prime movers in the school setting. While there are other mental health professionals, it's too bad that, or it's a sad reality that we don't have enough of this number in the school setting. And hence, the guidance counselors are therefore working very hard to implement what the law provides. But it's a sad reality, though, that in terms of the number of guidance counselors, DepEd dictates that there should be a ratio of 1:500. One guidance, it should be a registered guidance counselor, no? One registered guidance counselor is to 500 students in basic education. And when we say basic education, it will refer to K to 12, kindergarten up to senior high. And then for higher education, the ratio is 1:1,000. But as of the moment, with the 295 passers of the licensure examination and have taken oath, no, last October, there were only 295. making it a total of 5,032 as of the moment. No? Given the ratio that I've given early on, 1:500 and 1:1,000 for that matter. No? So on top of this, while the guidance counselors are the prime movers in school setting, up to this time, there is still a stigma attached to the guidance counselor. No? They would perceive the guidance counselor na panakot and would be equalized to that of a prefect of discipline, in which case it is the exact opposite. And that's one big challenge that we want to put across, na hindi kami mga halimaw. So, to exaggerate, no? But of course, no, we don't know what had happened in the past that we were given this impression. But we are trying our best, though, no, to be exemplifying what a true registered guidance counselor should be. And so, again, we are doing our best for that. No? So that's one of the challenges. Kulang na nga, tigre pa ang tingin sa amin. But of course, no, to be made for, to be more fair, in the private setting, gumaganda na. No? The depression now is now becoming positive. But in some public schools, it's still a problem. Why? Because instead of doing counseling supervision, what has been normally done is still on administrative. Yung mga paperworks, no, who are absent, who are present, and so all of this. Not on our main duty, supposedly, in counseling and in guidance counseling, no, and guiding our learners, for that matter. So that would be another challenge. And of course, other challenge is, like what I mentioned early on, again, the law tells us that there should be a complementation of the mental health professionals, be it in the school setting, be it in the workplace, or be it in the community. But again, in school setting, we have only an item, limited item, for guidance counselors. While there are a limited number of guidance counselors also, no, even the registered guidance counselor would not be that attractive to avail of the plantilla position in public schools, item as guidance counselor. Why? Because the salary is too low. No? Guidance counselors are just practical. No? We need to eat also. No? And yet, the requirement to become a guidance counselor is MA, and the salary is that of a bachelor's degree graduate. So you could see some kind of injustices though. And again, I would say that that's another challenge. The other challenge is for us to do capacity building for teachers. Because of the dearth of guidance counselors, we have to maximize the presence of teachers. And we've started doing that. And in doing it, in support, I saw our director here of Unilab, no, because we really are needing, no, personnel to help the guidance counselor deliver what is expected of them, no, in a school setting, especially in junior and senior high, in partnership with Unilab. Ma'am Lily, no. Ano nangangaw ka na yun, no? Yeah, is here, no? And we were able to develop 3 toolkits. Toolkits for registered guidance counselors, toolkits for homeroom advisors and classroom teachers, and toolkits for peer facilitators. This was our way in addressing the dearth of guidance counselors. So through this toolkit, there's an instruction, a module on how our classroom teachers would help address the concerns of our students. So that's one. And also we have the toolkit for peer facilitators. In fact, we have a national organization which we call the Peer Organization of the Philippines, no, POP. And I believe that is very much needed because with this junior high or senior high, this would be the kind of people that is want to, because they are their peers, no? They could easily open up sa mga kabarkada nila, no? Kagrupo nila, in the absence of guidance counselors, in the absence of or the lack of guidance associates or guidance designate for that matter, no? And we have that in school setting. And then again, since we are lacking guidance counselors, no, we have this POP in school setting. And I think this is one of the things that we could do to maximize the presence of our peer organization in the Philippines. So we have organizations in basic education, in DepEd, together with higher education. No? There are 20 schools, just 20 schools in basic education who have POP, peer organization of the Philippines, but we have 88 in higher education, 88 universities and colleges, no, with CHED, who have this peer organization in the Philippines. Okay, so that is how we are trying to reach out to our students in terms of capacity building through the toolkits, no, capacity building for guidance associate, capacity building for teachers, and even those in the human resource office. Okay, and the other challenge is how to attract or how to convince the present leadership of the basic education. Of course, again, stipulated in our law. I think that is in section 24 and 25. Ginawa ko ng Biblia, no, ang Mental Health Act of 20, no, of 11036. That's why I know where the section, no, that there should be a collaboration, there should be a complementation between and among the mental health professionals, no, in heightening awareness of mental health, in preventing, no, mental health conditions and mental health disorders, and in promoting mental health, and also giving intervention, no, therapeutic intervention to cases, no, with mental health conditions or mental health disorders. Okay, so in this case, we have TAP. And we, as an organization, I belong, no, I am the current president now of the Philippine Guidance and Counseling Association, and we have 31 local chapters, 31 PGCA local chapters spread out in the Philippines. And this is one big major advocacy on mental health. And normally, no, each of these chapters, in fact, I just came from Cebu last night, and the very team also is on mental health, specifically on evidence-based practices in handling trauma. You have a foreigner, no, who have undertaken, no, this training, and it's a 3-day thing, no, so it's still related to mental health. Okay, so again, going back to leadership and governance, we're trying to reach out to all heads of institutions in basic education, the principal or the head chef for that matter, in order for them not to be more oriented of what this mental health program is all about. And of course, with the guidance counselors in schools in place, we have the normal guidance program, but integrated to it is the mental health program. Okay, mental health program for our students, and mental health program including learners with diverse, no, with diverse culture, or shall we say the special, no, learners, no, or learners with special needs, no. So we have incorporated that as part of the mental health program. So it's not just the regular learners, but we were able to include inclusivity and diversity in the mental health program as part of the bigger umbrella of the guidance program of each school in basic education. Okay? And of course, the challenge there is how to monitor it, because we have already implemented it. And of course, prior to the development of the mental health program, as part of the umbrella of the guidance program, was this needs assessment. We did needs assessment already, in order that the kind of mental health program in each of the schools would be what are very much needed in relation to mental health. We have done that, needs assessment. But the more challenge now is to monitor and then eventually to have them be evaluated at the end of the day. Okay. Another challenge that we are facing is the conduct of research. Research in school setting, especially in basic education, is not that much welcome. But in higher education, yes, because that's one of the areas. In higher education, we have teaching and learning, we have extension, community service, we have research. But in basic education, research that's not so much embraced yet. So hence, that's one of the concerns in basic education, for us to capacitate them, to give them, to upskill them in terms of the competence in doing research. Yung kahit mga simple research lang, because what we tell our guidance counselors with the help of the psychometricians, is to simply gather all data what is in the guidance office. That alone, data in the guidance office, in cases, in learners' cases, not just in mental health, are kept in the guidance center, in the guidance office. And so we encourage them to make use of this data, simply playing with variables, to come up with research. And we also have started upskilling guidance counselors in basic education on qualitative research. And we do believe that qualitative research is very much needed also to add on to what is quantitative, that are seen in the guidance center. Okay. So I think I believe these are some of the challenges that we have yet to face. And of course, one of the challenges is how to sustain such program, especially in private basic education. Why? In some basic education schools, they don't have, or they have very limited fee for guidance and service, for guidance services. So much so that if there is a very limited fee for guidance services, including that of mental health service in doing referral, more so that there are no funds for research. And so the challenge that we do give them is simply that in considering promotion, faculty reclassification, so they have added points if they do conduct research. So that's the only thing that we could do. And also, on the part of our organization, Philippine Guidance and Counseling Association, we have a regular research journal where guidance counselors have to share their research. Okay, so in fact, this is now one avenue to encourage, to motivate our guidance counselors to do this research. And starting 2021, the theme of our research journal is on mental health. In fact, I was then planning to bring some research journals in guidance and counseling, to show you what would be the topics there. Nalimutan ko lang, but I really intend to do it. Na magdala doon. Since 2021, the team has something to do with mental health. No? All in school setting. Ito. Okay? So hence, given these challenges of mental health professionals in basic education, it is always a desire, no? And not only a desire, but we are putting into action the saying that mental health professionals should be the gatekeepers, no? To have a healthy well-being. So on that note, I think that's all. Maraming salamat sa inyo lahat.
So last but not the least, our third panelist is a notable figure in the health and biotech sectors. As the health lead at Ignite Impact Fund, a Philippine-focused impact investment fund, she directs funding to high-impact ventures. She's also a senior partner of Upscale Innovation Hub at the University of the Philippines, a founding member of the Gender Lens Investment Council, and advises DOST PCHRD. Her extensive background in public health innovation includes serving as a doctor to the barrio and working with the University of the Philippines National Telehealth Center. In 2018, she founded the biomedical device startup Veris Tech. Additionally, KM has been a panelist and advisor for various startup incubation programs, both domestically and internationally. She led the Helia Castillo Awards for research in social innovation in health training program successfully for 2 runs and volunteers as a mentor at Techstars Startup Weekend Manila. Her academic qualification includes Doctor of Medicine degree from the University of the Philippines Intramed program and a master's in public management with a focus on health systems and development from the Development Academy of the Philippines. KM has further honed her expertise through training from institutions like our institution, the Asian Institute of Management, the University of Oxford, and the UK Royal Academy of Engineering and the Asia Venture Philanthropy Network. Let us welcome Dr. K.M. Magtubo, who will discuss the role of impact first investing in sustaining and scaling mental health initiatives in the basic education sector. Doc K.M.
Thank you. Thank you very much for having me. I think I have a presentation. Did you send it? Yeah. So while they're loading, thank you very much for having me. My name is KM. I'm a medical doctor, currently practices investment. So I feel like I'm learning much more by being here in the practice, but hopefully I can contribute something to the discussion from the lens of impact investing. So while they're looking for the presentation that I sent them earlier, I feel like we should do parang a disambiguation of terms. You know? So impact investing, I feel like it's a term that's been tossed around the last couple of years, especially with the rise of the COVID-19 pandemic and the deluge of capital into social services, right? Healthcare, welfare, etc. So when we say, ayan, ang saya, diba? Ayan, I was prepared. Sige, can we go full screen and then go to the next slide, please? I believe in you. There, and then let's go to the next slide. So why did impact investing come about? So impact investing is a response to the need for capital in addressing the SDGs. So the last 10 years, we figured out that the SDG funding gap is a lot. It's 2.5 trillion US dollars, right? And then specific sectors that are critical to the SDGs, like healthcare, consist 40% of that gap. Furthermore, next slide, we also figured out that the global financial market is worth $700 billion US dollars. So if we could just align even 1.1% of the global money, of all the money circulating in capital markets all over the world, we will achieve the SDGs. This is basically the mission of impact investing, is to realign all that capital into things that create impact, right? So next slide. As the introduction earlier said, impact investing is investing in companies, organizations, and funds with the intention to generate measurable social and environmental impact. And as I said, there's a lot of terminology that comes along with impact investing. There's ESG investing, social finance, venture philanthropy, impact financing. Don't worry, because even us as practitioners don't agree on where the terms end and merge, right? So it's an emerging discipline. What we understand is there are two basic components. So first is investment. So there has to be an exchange of funds, right? Investment in companies, organizations, and funds. So in entities. So we don't put money in projects or people or it has to be an organization or a company or a fund, and there has to be measurable impact. So this is parang the key component of impact investing as opposed to regular investing, is the demonstration of effect, the demonstration of impact. We are very, very concerned with measuring and monitoring and demonstrating that your dollar value equates to this much turning of the needle towards the better direction for the SDGs. Right? Next slide, please. So when we think of impact investing, who is an impact investor, who is not an impact investor? So again, there are a lot of terms and a lot of debate, but the way that I like to look at it is as a spectrum of capital. So on the y-axis, if you think about when you invest, what is your expected financial return? So what profit are you looking at? And on the x-axis, what is the outcome or the impact that you're looking at? When you say, as they said in their brief, impact first investing, that means that you are intentional in creating your impact at either at the below market rate impact investments. Yan, tama yan, there, that arrow. So that means na, if it means na you take lesser profit, right, that's okay, as long as you get more impact. Right? Now, I highlighted the one above it, which is intentional market rate impact investments, which means you want the most profit that you can have and the most impact that you can have as well, right? Because most impact investors would align themselves in that box, not actually the below market rate impact investing, right? So there are fewer impact first, profit second investors in the field than there are impact and business together, right? Impact and profit together. So Ignite Impact Fund, where I work, we align ourselves with the, because we are very aspirational and we would like to change the world. So we align ourselves to the rightmost, evidence-based impact investments. What do we mean by this? We invest in solutions that have been shown to provide outcomes, right? To drive impact. And if it means that we get either just partial capital recovery, no profit at all, or below market rate, that's fine, as long as we maximize the evidence-based impact. And we do this, next slide, there, by investing in companies, only companies that help to achieve any of the 17 SDGs. So we don't invest in companies that are not SDG focused. We also only invest in the Philippines because this is where we live and this is where we want to make the impact. And the companies that we invest in must commit to our proprietary transparency and monitoring metrics because we want evidence-based impact, right? So next slide. So there. When we say SDGs, mental health, investing in mental health, what do we understand that as an investor? So earlier it was mentioned SDG 3.4, but actually the way that we look at it in market research, that includes SDG 3.5 as well. So that includes reducing mortality from NCDs, which can cause also secondary mental health disorders and promote mental health, and preventing and treating substance abuse as well. So next slide, please. In the global market, eto na. So how much money is in the global mental health market right now? So in 2020, the global value of the mental health market was estimated at 383 billion US dollars. With the steep rise, as you can see on the figure on the left, between 2019 and 2021, coinciding with the pandemic. So with the rise of the pandemic, the rise of the use of technology, and I highlighted their financial technology, fintech, the ubiquity of electronic cash through which providers could get payment, there was a lot of investment into tech platforms that extended usual avenues for therapy and for counseling. So yung mga teletherapies and telecounseling methodologies. The focus sector, or the biggest sector that has been growing in the global mental health market, is, not surprisingly, child and adolescent health, right? With a projected growth rate of 3.2%, right? And if we look at the statistics that were presented earlier, that makes sense, because all throughout the past 5 years, that sector really has been growing in demand as well. And then another focus sector is depression, more than anxiety. The largest segment, also not surprisingly, is digital and technology. So not a lot of research and development, or a lot of money is going to R&D for new drugs, for example, new modalities of inpatient therapy. A lot of the funding in the global mental health market is going into digital and technology solutions for mental health problems. Next slide, please. Right. So in the Philippines, I think we've seen this. In the Philippines, we all referred to the same report. So in the Philippines, this is the burden of mental health conditions. Next slide. I think I just expanded. Yes. And in the Philippines, the investment that we require is actually 2.5 billion US dollars. So if you look at the global value, 383 billion US dollars, this is about 1%. Just 1% of the global, the amount of money that's circulating around the world for mental health would solve all of the Philippines' mental health problems, right? That's why we need to convince investors to invest in mental health. Next slide, please. What are the examples of mental health technologies that have been invested in the Philippines? So these are homegrown mental health startups that have received investment in the last 3 years. So Empath is a teletherapy platform. Aruga is actually homegrown from MSIB students from AIM, proud. Infinite Care is mental health care for your workforce. So they partner with businesses to provide mental health support to their employees, and mind you, is essentially the same. What is the common thread in these 4 startups now that we can observe as kind of a generalization in the mental health space in the Philippines? First, they start with business to customer, meaning the business, for example, Empath, engages with the customer and the customer pays for the service. That makes sense because they can pay through GCash, they can pay through PayMaya, and Empath can pay the clinicians, right, directly. The second feature of these 4 startups is they engaged with businesses, with employers. Why? Because mental health is already covered by various HMOs, right? So these businesses provide their employees with health coverage, with health insurance that includes mental health, and these startups can charge against that mental health benefit whatever services that employee accesses. So it's the provider payment mechanism that often determines what the structure is that complements the mental health space, right? So how do we pay the providers? And that's a thread not just for mental health, but for all health startups. The thing that most innovators forget to think about when they innovate in the health space, health tech space, is how do you pay the providers, right? Is there a convenient way for the providers to get payment? And for these 4 startups, they figured out na HMOs are a convenient way to do that. So something for us to think about, thinking about school-based mental health programs. Is there a convenient way to pay guidance counselors? Is there a convenient way to pay therapists that are providing services to the children? Next slide, please. All right. So having said that, there are examples elsewhere of successful school-based health programs. So Daybreak Health is from the United States. They're an online teletherapy platform that are in 60 school districts in 6 states in the United States. And their revenue, see, look at that. The revenue comes from school district contracts. So there's a base payment, like a subscription payment, and health insurance claims. Because in the US, mental health, you can charge against Medicare and Medicaid. So it's very easy for them to access the services, for them, meaning the patients, to access the services. And it's also easy for Daybreak to collect payment for their clinicians. As of 2020, they report that 81% of their students showed symptomatic and behavioral improvements. And this company is currently worth 25 million US dollars since their inception in 2020, in 3 years. So such a huge spike in valuation because of the demonstration of effect, right? Another example, this one is not school-based mental health, but more an inpatient care facility for substance abuse. This is from New South Wales in Australia. I saw that there's someone from Australia in the chat. Hello. So I'm not sure. Chime in if you know this. So the Resolve Social Benefit Bond is a different organization altogether. So what happens is Resolve is a program, no? So it's a step-by-step program delivered by a startup, a company called Flourish in Australia. And they were contracted by the government of New South Wales to deliver a program that would combine a residential service, integrated psychosocial, medical, and mental health support, and a warm line for after the patients get discharged. So for the outcomes, so if they're able to increase the or decrease the DALYs, increase the emotional state of the patients, they get paid by the New South Wales government, right? And the investors invest into Resolve, and then only if their outcomes are their savings as well. So what are the results now? So by 2022, the New South Wales government saved 40 million Australian dollars in providing, so because they didn't provide the care themselves. Resolve provided the care, right? And Resolve was paid 2.8 million Australian dollars because of the outcomes of their patients. So this is a different model of a government entity contracting a private entity to deliver services. And you only get paid if the outcomes are there, if the outcomes are met, which is something that you would have already agreed to before the contracting. So this is a social impact bond or social benefit bond that also exists for mental health. So you can read the report. This is a 5-year program, I think, and they're ending this year. But it was very successful. Next slide, please. So what are the considerations now in investing in mental health now from an impact investor perspective? My first question always is regulation and standards. There's so many, so many mental health apps that are being born every day. Even in the Philippines, whenever I participate in an incubation program or a startup weekend, mental health is always one of the top line priorities for the youth. And that makes sense because it's a felt need that they want to address. But what's the rigor and ethics behind these startups? Typically, when you work in the technology sector, there's a move fast and break things ethos. But that doesn't really make sense for health because we're talking about patients' lives and patient safety. So what are the regulation and standards around innovating in this space that might be able to guide investors as to what's a good investment and what's not a good investment? The second is, how do we embed the research practice into these businesses? into these startups. We're asking them to provide us evidence of outcomes, to provide us with measures and metrics, but they don't know how to do that. So how do we embed that into the startup model in such a way that does not derail their progress as well? How do we get these technologies or these innovations into underserved populations like our LGBTQ communities, our indigenous population? Are there specific needs, there niche needs that we're not seeing, that we're not serving, right? And what would be the risks or effects of the deluge of money into the mental health tech space on traditional practice? Do we, at the risk of being being battered by my colleagues, do we now shift all of the therapies online? Do we no longer need psychiatrists? What will happen now, right? So these are some of the considerations that I would like for everyone and us to explore. So I think I'm ending there. Next slide. Yes, so this is me. If you would like to get in touch, and I am really look forward to speaking with everyone and discussing.
Okay, thank you very much, Dr. K.M. Magtubo. And it's good that you were able to touch on the mental health applications that are currently present and proliferating in the mental health ecosystem, no? And a lot of things that are presently in the presently being questioned right now is the ethical standards of these mental health applications. We we do have a lot, and we are seeing a lot more even abroad. However, the research component of these applications are always put into question because there aren't a lot of um, evidence-based um evidence-based uh, research, no, that will tell us that these applications are effective. These applications are actually doing what it is supposed to do. Okay, let me invite all of our panelists. No, unfortunately, we have our fourth panelist. Sorry, uh, we unfortunately Doc Asek Galban is not able to is unable to come here right now because he's in the Senate, and there is a budget hearing. If I'm, yeah, he's in the Senate right now. However, we have a uh, very good mix of panelists right with me, Dr. Bongkahes, Dr. Ines, and Dr. Magtubo, who will join me here in front. uh, Doc Reyes, can I also invite you to be part of the of the I'll stand up na lang. To be part of the panel as well. You were about Okay, let me ask. Um, let us take off with the proliferation of mental health applications because there are a lot. We have been seeing a lot of mental health applications, and even with applications right now, with Aruga. Aruga is a mental health application, no? And where do we draw the line in terms of when we are discussing the ethical consideration for these applications? Okay. Rodney?
I am thinking as my thinking hat now is a technical working group of the Philippine Council for Mental Health. Kasi this has been brought to the council, I think, several times that there are many apps regarding mental health. The problem now or the concern is about the regulation or maybe standardization of the content because we have been experiencing the impact of this app. Kasi for example, we are still practicing psychiatrists. Parang patients or service users would ask us, Doc, I need consultation when asked for a specific reason. Kasi po I scored ganito, I think I have ADHD. How? How did you know that you have ADHD? Kasi I answered an app and then it says na may ADHD ako. So something like that. So I'm still as a technical working group member of the Philippine Council for Mental Health, I think this concern or issue has to be resolved. We have recently finished the workshop on the specific strategic strategies or strategic workshop for the next 4 years. So maybe we can include this in one of the agenda because it's really something that is bothersome or of course needing attention. Yeah.
Okay. Dr. Hines, Dr. Reyes, Dr. Reyes. You know, I love putting people on the spotlight.
Well, taking the lead in such regulation, no, should be the Department of Health, of course. No? And the Department of Health should be the one to get the cooperation of the civil society, like the association, Philippine Psychiatric Association, Philippine Guidance Council, to put in certain guidelines for them to implement. No? Walang pinagkaiba yan sa diagnosis ng albularyo at diagnosis ng doktor. No? So the body, governing body that should take the lead should be the government. No? In setting the standards. It's true, no, that there are so many applications for this, no, mental health, no, and they're not even. I was talking to Dr. Hines kanina. They're not even standardized, no, and in terms of making use of it, in terms of impact investing, no, impact first investing, no, wherein the investor will try to get scale, measurement of how effective this program. You cannot answer it. Baksak ang ano mo, hindi ka na i-investan. Right? So that's precisely the point that every application or every self-help or tool, screening tool, checklist, whatever you call it, no, should be standardized, no? Mas maganda nga standardized to the Filipino people, eh. No, not Western, no. Yeah, you know very well that culturally speaking, we're very different from them. You know? We have, the values, our values and beliefs are quite different. So, ganun. My answer to that is yes. No, we should really check on it. No, and the body that should, the government agency should be in the lead for that.
Thank you, Dr. Reyes. Dr. Hines?
Okay. Yes, I do agree with Doc Noel that we have to have some kind of measuring tools to have this be standardized. And again, as you have mentioned early on, the culture of the user, no, would be considered, that it should be culture-based. And we have learned this in any subject in measurement, be it in testing and everything, you know, that, and also the uniformity of its administration in terms of its scoring interpretation, if this is a tool, if this is assessment tool, so that is to be considered in the context of the user, no less than the Filipinos, no? And then also, they have to, I would wish, no, I would expect that those who will make any tool should be experts in themselves. No, because if they would simply get it from anywhere else and then put it there, then the users, no, would be at stake. Instead of giving some kind of help, then it may worsen the end user. So I think that's all.
Dr. KM?
Yeah, I guess nothing to add except siguro I might address the innovators themselves, no. Just to make to impress the point that regulation is not the enemy of innovation. Regulation exists in order to keep our patients safe, in order to have these spaces where we can safely explore the boundaries of technology, the boundaries of our practice without harming our patients, which should be the center of whatever innovation you're doing. So while we're talking about, regulating, innovating in the telemental health space or in the digital mental health space, don't think that we're stifling your instincts or your stifling your right to innovate. It's what we're concerned about is ultimately what you should be concerned about, which is patient safety, right? So yeah, yun lang. Just in case may innovators
Yes.
nakikinig.
Yes. And a follow-up question on that, no? Most of what Dr. KM you have presented, the mental health applications you have presented, are more on the here, especially here in the Philippines, they are more concentrated on the working age group, the young adult, no? And we haven't, I have yet to see uh, mental health application or a mental health group wherein they focus mostly on the adolescents, no, and most of them are in the business to customer, no, is a business to customer type of approach or ethical, or somehow do we need to have a business to business approach in dealing with school-based mental health programs, specifically if it is started by an impact in a company that is gearing towards these kinds of interventions.
Well, there are many layers to that question. No? Is B2C more ethical than B2B? Is B2B more ethical? I don't think the form of the business determines the ethics of the business, right? It's ethical if it conforms to
Conforms to the-
ethical standards, right? I think the advantage kasi of making it B2C is that your obligations to the user are stated in the end user license agreement, the EULA, and nobody reads that, right? So you just click accept, I accept, continue with the service. Have you read that on your iPhones or your smartphones? No, right? Did you know that your iPhone sends periodic measurements of your location to Apple? You don't know because you didn't read the EULA, right? So that's kind of the manufacturer or the innovator trusting you to take control or to take responsibility and accountability of yourself, right? I don't think that's something that we can trust 5 to 14-year-olds to do.
Yes.
Right? And that's why if you look at the model of Daybreak, right, the school, their contracts are with the school districts. The school is kind of the proxy parent for the students that are accessing the care. No, well, why they do have guidance counselors, even in the States, they are in short supply. So what Daybreak does is to para extend the services of the guidance counselor so that the guidance counselor can focus on the more severe cases, right? And so that there's early intervention, right? And then they've linked the mental health measurements that they do with school performance, and that's why the school districts also support them. So in that sense, the B2B model makes sense, right? Yeah, yun. So that's my answer.
Yes,
In
Dr.
my
Ra.
case, no, I have a very brief answer, no, which is related to this ethical standard that simply do no harm. The intention is understandable by the maker and the user. And so in terms of its delivery, the goal should be do no harm because intention is good.
And that's precisely the essence of impact first investing. It is going beyond do no harm, but to do intentional good, one step higher. That's impact. That's the essence of impact first. So you just don't do harm. You do one step higher. You intentionally do good things, and that's the reason why my answer to that in terms of ethical. I don't go into impact first because you're precisely going the opposite.
Don't pitch to impact first
Yeah.
investors.
Because if you're going to invest using impact first investment policy, no, actually you are ethical at the start already because you are doing you are trying. It's not business. Business is a side benefit. The primary is to help social, environmental, and other of the marginalized people do earn more or do well. No, so in terms of that ethical consideration, no, you should not be going into it. No, doon ka na lang sa traditional investing, wherein the main purpose is the return of investment. No, but if you are, di ba, much more what is not impact first investing. It's not also philanthropic investing kasi you have a gain pa naman eh. Pero it's a sideline. No, not that's not your priority. Right?
That's what we call the social return of investment. Wherein we are able to give emphasis on how it impacts the lives of so many people. So many people in terms of specifically for school-based mental health, the mental health of our learners. No. Okay. We have a question on Zoom. Where wait. Yung una, okay. By the year 2020, 2030, what are scenarios of how would mental health tech businesses fill in the health service gap? I think that's a very good question, right? Rodney, I know you are in the development sector.
Sige,
I think you
the
can
question
answer
is by
this one.
2030, what are the scenarios of how would mental health tech businesses fill the mental health service gap? Okay. Sige. Seeing the importance of technology during the COVID-19, di ba? Because of the limited access to health services, I think we all know that amongst the clinicians who have really gained well on that are the psychiatrists because we can do consultations and mental health professionals in short because we can do consultations online. We do not need to see the patient physically or the service user physically because as compared to other practitioners who would be needing auscultation, the use of physical examination, nag-flourish yung use of telemedicine because or psychiatric mental health condition services because of the yung setting na pwede siya doon sa telemental health. So I think with by 2030 konti pa rin naman ng psychiatrists by that time siguro or maybe the psychiatrists now are focused more on the more severe cases and individuals who might be at risk or individuals who might want to promote their mental wellness can take access on services maybe that can be provided using the modern technology para ma-improve yung kanilang condition so that the psychiatrist now can focus on those individuals who are more of the professional needs. So, yan. Kasi tinitingnan natin yung mental health na hindi na lang yung may sakit na, kundi yun ding nangangailangan because they are at risk or those individual who would like to promote their mental well-being. So, maybe at certain point, our tech can really fill in the gap.
Yes, Dr.
Ako,
Im.
may sagot ako dito because I cut this from my from my presentation to keep it 10 minutes. Three trends are arising. Okay, so first one is in digital mental health, the use of artificial intelligence. So artificial intelligence not only chatbots, which we're very familiar with, but also neural networks in order to facilitate diagnosis, the use of sensors to collect other data than speech and yung content ng speech in order to create a diagnosis. That's a trend. So we might see maybe someday um, an AI diagnosing someone with severe depression using a video of that person, calculating yung little perspiration dots, the changes in the body language in the face or in the hands to see that this patient is also in crisis. So something like that. The second one is expanding patient choice. So because of the deluge nga that we've already seen of mental health apps, we also see patients who are actively taking control of their choice of practitioner. So because they have a lot of options, no, there's already BetterHelp in the Philippines, right? So they can even choose to consult with a psychiatrist who is not Filipino, right? Who is from another culture, another country. We're looking at an expansion of patient choice in such a way na the normal clinic paradigm of the doctor will see you now will flip and it will become the patient will see you now, right? So the third thing that's also kind of prevalent is yung the expansion of services for niche groups. So we already see this in the UK, in other countries where it's more not more prevalent, but where they're probably more social aware. But services specifically, for example, for LGBTQIA communities, services specifically for trans children, specifically for Black women and children. So there's a wonderful app called Shine that's specifically for BIPOC people, yeah, for resources for them. So those are the three trends that we're seeing globally. Whether or not that will affect the Philippines, right? Because healthcare and mental health is very context specific. We don't know, but globally at least that's the outlook.
So there is more of democratization of the entire mental health
Yes.
ecosystem as we move to the digital age.
Yes.
Now, another question I have in mind. No, most of the mental health applications are in the intervention space. No, I would like to touch base on how about on the primary and secondary levels of care. Primary level of care is on the promotion and well, we have this promotion prevention, and then the secondary level of care we have screening and the referral system. Do you think we should also invest more on the primary and secondary level of care, given that given that a lot of the mental health applications are focused or are already on the tertiary level of care, which is the interventions, teleconsultations?
The way I look at it, no, as we progress, no, year by year, and probably going beyond 2030, primary and secondary is in order. Yeah, yeah, it would be, no, in place. But in terms of intervention, probably it's something personal on me that while we could do a lot of medication, use of pharmacology and all of these things, no, but that to me personally, the human touch is another thing. So if there could be a balance between what is in the intermediate and the person to person, specifically in the showing of emotions, no, the touch, no, because a lot of researchers would guide us that human touch is something different. So to me, there should be a balance of this. While this intervention through the use of AI admittedly would be in place, but not exactly to replace the presence of the human person.
Yes, and I do think it's also important that in applications like this, wherein it is verified by a mental health practitioner. Anything that will actually test, anyone who will actually test positive will have to be verified by a mental health practitioner, either by a clinical psychologist, a guidance counselor, or a psychiatrist. No? Doc KM. Doc Noel. We have to keep it light.
Yeah, I will. We've all agreed that the mental health issue in the country is nearing crisis level based on the data that was presented. Therefore, individualized or target intervention should not be the case, but let us treat mental health as a public health issue already. And if you are treating some disease as a public health issue, then all levels of treatment should be addressed, whether it's primary, whether it's secondary, whether it's tertiary. No? Equal dapat yan. Much more nga kung sa preventive promotive aspect, advocacy. No? The first, of course, should be destigmatization. It prevents a person from seeking help. No? So may services ka nga, hindi naman pumupunta sa'yo, then useless. Then all should be included. Addressed all. No? Now, in the previous question about 2030, no, I could just say in terms of me being the medical center chief for the National Center for Mental Health, all our efforts are geared, all our strategic planning, all our reframing of services is geared towards 2030. No? And I can say that based on our timelines, based on our, what do you call that, roadmaps, no? That by 2030, NCMH should have decreased its bed capacity. Decrease. Why? Because by that time, NCMH should have capacitated community mental health centers. No? So it follows. No? One more, by 2030, our IT infra should be at par. You know why? Because NCMH is a research center, supposed to be. It's a reference center. And by that term alone, our IT infra should be mabilis. No? We are supposed to be a repository of in terms of mental health researches. So by 2030, that's our target. Any policy, any program, or any initiative, for that matter, no, would be coming from a question, right? Nagtataka ka, you are curious. Why is ganito? Then you do research. Then upon the result of your research, now you can translate that into a policy. No? So that's hopefully NCMH can live up to the mandate that is being thrown at NCMH, no? Based on the law, Mental Health Act 11036, Universal Health Care Act, which entails equity, equal, no, in terms of evidence-based treatments and other modalities, available to all people, no, all Filipinos. Okay, so not only that, no, because NCMH is the mother agency is Department of Health. Department of Health also has some mandates thrown to us, no? So marami. And not to mention our own mission and vision, our own objectives on why we are existing, no, NCMH. So lahat yan, we'll try to harmonize it, no, and come up with these roadmaps. And hopefully by 2030, yeah, I agree that it is technology based. No, I presented earlier that there are 0.633 psychiatrists per 100,000 population. No, and so we really cannot reach far and wide. No, what we can reach is here and there. No, but technology makes us available, no, to the far-flung areas as long as they have internet service. No, so really, IT, no, technology plays a major role in terms of our service provision in the coming years. As a center, we're also preparing for that. We're upgrading our infra, IT infra, no, to handle all of this. No. Nagulat nga ako, no, nakakagulat. Napupuno pala ang memory ng ano, sa dami ng sa dami. So I need to really upgrade all the server, tapos data banking, no, everything. So that's my answer to that question.
May dadagdag lang ako siguro, Apons, na do we need to invest on prevention and promotion? Yes, definitely, no. If you will see mental health conditions, only a part of the population would have certain conditions at a given time, but the majority of the Filipino people would really need to improve on mental health literacy. So this is one of the strategic focus of the Philippine Council for Mental Health strategy map for 2024 to 2028. So aside from improving the services for those who have already afflicted with mental health condition, is as well improving mental health literacy, so that eventually people would be more aware of what they can do to improve their resilience to stressful situation, preventing them from having mental health conditions, or maybe at least helping other people identify, especially those who have difficulties in reaching out to people who would be helpful to them. Yeah.
Thank you. How about on the screening and referral pathway? I know it's important to be literate about your own mental health, no? But one critical aspect is the screening and then timely referral to mental health professionals, no? How ready is the mental health ecosystem for interventions like this? Especially if we are going to make it a tech-based, web-based app.
Yeah, one of the initiatives of the National Center for Mental Health is the genomics study. No, if you're asking about screening, is anybody familiar with newborn screening? You have a child. So upon birth, they're being extracted blood for newborn screening. Diyan malalaman kung lactose intolerant, kung congenital, all right. Now, the NCMH now is undergoing collaboration with the Philippine Genome Society, wherein sample is being discussed, which sample, hair, blood, tissue, what else, whatever, and to find out markers for psychiatric conditions. If you have TB markers at birth that you're going to be prone to pulmonary tuberculosis, sooner or later we'll have some markers identified for depression, for anxiety, no? So for screening, like newborn screening, na automatic yan at all pang-anakan, no? Pwede rin natin gawin yon sa psychiatry. One more thing, kasi both yan no, yung genomics, no, for screening, and the other one is finding out which treatment you would benefit from the most. No? If you're diagnosed with depression and you do your genome line, no, makikita natin what antidepressant would be very best for you. So both ways. No? NCMH is already starting up, no, starting that up, no, with the collaboration with the Philippine Genome Society Council pala. Thank you.
Rodney?
Uh, yung sinasabi ni Sir kanina is more on the syempre health-based institution, no?
Health-based,
Pero when
on
it
the
comes to
community.
screening, it's more of an inter agency collaboration and everything. Kasi for example, when we are looking on the settings, there is mental health at the community setting. There is mental health at the learning institution setting. There are mental health at the workplace setting, and then mental health facility based. So when it comes to readiness, ay wala si Asik Galban eh. Siya yung magsasabi ng readiness
He'll be the
ng
one to answer this
ng
if he
ng
was here.
DepEd, di ba? Pero yun nga, kasama din sa mga pinag-uusapan ng council is the capacitation or the improving of mental health literacy would include arming our professionals, be it at the academe, at the workplace, or at the community of this learnings or kung paano yung mag-screen. Kasi sabi nga natin, screening and identification kasi the rest of the work would be on the specialist or on the practitioner, di ba? Pero the screening as the one of the basic na kailangan, this is more of a population-based intervention. Ano siya, talagang everyone. It should not be the sole responsibility of the Department of Health or the medical professionals, but must be an inner capacity of other people as well, especially those in the workplace, in the academy, or even in the community.
I just want to add lang na that would be a prime kind of spot for innovation, right? So in other areas, not just in the mental health space, we've seen task shifting happen. No, so for example, like midwives and nurses are able to diagnose hypertension and refer accordingly, or diagnose that this person is at risk for HIV and refer for testing accordingly. Yung task shifting that's aided by technology, you know, where they have an app with a checklist and the checklist would automatically compute, yes, this person should be referred. That's a prime, ayan o, so mga innovators. That's a prime, mga innovators, hello. That's a prime spot, you know, for innovation, and that's the kind of innovation that we would like to fund, right? That we would like to see. Kasi that's, as they said, you know, if it's a crisis, then population-based intervention should be considered and population-based innovation should be funded, right? So that's the kind of stuff now we'd like to see as well. So if somebody gets inspired, you know, you have my email address.
Yes, bro. Yes, Doc KM. Yes, for the school
yeah,
days
yeah.
specifically.
I was struck by the statement of Dr. Noel early on that we are now going to the direction of mental health to be in crisis. And so in the school setting, in relation to screening, the answer is no, both in basic and higher education. The kind of screening tools that we have in school, probably one or two in terms of screening tool in mental health. If we have a mental health condition, no, I know of one or two who develop it, but in terms of standardizing it, it has yet to be standardized that there should be a national norm for that, no, and then probably even the AIDS norm could be considered. No? So that's one. And there are no screening tools in terms of mental health condition, anxiety, depression, and any other mental health disorder. If we have, they are all foreign made. They are all Western made. In which case, I do believe that it should not be. Again, we have to consider always the culture. Yeah, so, and that is one challenge that we could take, and we'd probably connect this impact first investment. If there could be a foundation to support in the development of screening tools in both basic education and higher education, then impact-based investment would be there.
Yes, Doc.
Ma'am, hindi kailangan. So kung meron po kayong idea on how to do that, you can present it as a research proposal to the Philippine Council for Health Research and Development. Mm. So, and they will fund that. They are undersubscribed most of the time. Yeah. So you can develop that as a research project, right? And then when it can become commercial, you know my email address. so that we can
Yes,
scale
point
it
of
up so that
collaboration.
we can scale it
Point
up
of
and it can reach more Filipinos, right? So it can begin as a collaborate between the and then and then funded by, PCHRD maybe. Naku, baka saksakin ako ng mga taga PCHRD. But they do fund research projects like that. And mental health is one of the priorities in the NURA, in the National Unified Health Research Agenda. So it is possible to get funding for that, and that is a possibility to happen.
And I think it's important.
I want to add also that this is not only in terms of mental health screening tools, but in all other psychological assessment tools.
Yes.
They're all westernized. And I would say that there is this very big violation in terms of the implementation of ethics in this use. Puro, they would simply use it without establishing local norm for the Filipinos, something like that. Sabi ko, wow, this is a very big no-no. But it's a practice, ongoing practice. But who is going, But is going to say, you're violating the ethical standard of assessment. Nobody do it.
It's important that we are able to contextualize it in the Filipino setting. That's what we are actually looking into, refining the research methodology on the screening platform that we are, if we are going to develop this, it's important to really contextualize it down to the cultural norms of the Filipino people, and at the same time put into context the knowledge and expertise of our Filipino mental health practitioners, And I think this is where
And to add to, since you have mentioned already that we have to put the expertise and the knowledge, we were trying to come up with operational definition of what is an evidence-based practice is all about.
Yes,
Because at times we would make use of this term, but it's not grounded, meaning that there are no parameters, there are no criteria where they would be really called as this is an evidence-based practice. Based on what? So it should be based on empirical results, meaning that there should be a lot of studies conducted, and the results should show that there is an effective outcome together with the expected effectiveness of the empirical study that you have conducted. Number one is number two would be the clinical expertise. Who did it?
yes.
In terms of the tools or in terms of the intervention, is this the work of the expert? And number three, how about the characteristics of the clients, their beliefs, their values, the traits, the culture, and so on. So these are the three, These are the three criteria to identify a treatment or an intervention to be labeled as evidence-based practices.
Okay. Yes. And another question wherein I would want to touch base on, how can mental health professionals and impact first investors collaborate to be able to make, let's say, fruitful and at the same time impactful programs specifically for the school-based sector?
Well, maraming ways Like for example is yung technical expertise ng bawat isa. Like for example in program development, needs assessment, monitoring, screening, something. So parehong merong kanya-kanyang expertise yung dalawang field that can really collaborate and come up with a good project or something that is very useful to many. So yun, some of those would be what I have mentioned. Program development, needs assessment, yeah.
That's the reason why the challenge that was posed by one of the
By Dr.
challenge.
Hines.
Yes, she spoke of the challenges, no, kanina. And one of the challenges is the Department of Education teachers, how to collaborate with them. Oh. And they're the ones who will notice the first sign of indifference from students, sign of sadness, biglang nalungkot, biglang naging hindi interactive, no? But unfortunately, with the present Secretary of Education, they release an administrative order that teachers are teachers, no? That they should be limited to that, no? That nawala na yung ano
That puts the burden again to the mental health
to the
professionals.
mental health professionals, yeah. So naging napunta ulit doon that they should not be tapped, no, to do counseling, basic counseling, no, to identify red flags, no. Very unfortunate, yeah. And that's why I think Dr. Hines mentioned it as a challenge.
It is a challenge indeed.
I have a basis for that. No, at the height of the approval of this Mental Health Act in 2018, I was invited in the University Belt to talk about mental health already. Kasi talagang nagpo-popularize na ang kwan po, no, the act to be approved na. They are all senior, junior, and faculty members here in Manila. More so if you would consider it in the province. So just to titillate them, if I may use the term not titillate, just exaggerate, no? So what's your concept of mental health? And then they keep on answering on the white screen. The first answer is brokenness. Your concept of mental health, ano, what do you associate? Brokenness. If I may exaggerate, nung nakuan ko, no, and then 50 po ang yung sumagot out of 2,000 audience. Number 2, sadness. Palikod ako ng palikod. First, second, and third choices, all negative. And then the fourth one, state of well-being. 1 step forward, 3 steps forward ako. So meaning, just to show na every now and then, negative, negative. First, second, third, negative. And on the fourth, state of well-being, okay, positive. And then all the rest, negative. I think that is one, no? That they do not know yet the concept of mental health. But if you are going to find the definition of mental health in the law, it's very positive. And that is already, that's already an activity in itself, no? It is state of well-being where every individual, no, realizes its potentialities. So self-awareness na muna yun . You could do that in school setting. You could do that as an activity already, no, to know who you are. Self-awareness na yun. But too sad, no? That one reason why these teachers would not know or would have a negative impression before was because they are not aware or they don't know the real concept of mental health, which is very positive. Very negative ang alam . Students and teachers.
So the first step of Dr. Bongka is in terms of mental health literacy is the teachers. Yeah, the teachers, not the students.
Dr. Bucayes, you have a lot of work to do.
Kaya nga sana nandito si Asik Galban, no? Para ipapasa natin
So we
kay
can
Asik
pass.
Galban. Yeah.
We have some online questions here. Okay. Currently, the mental health applications require some payments, and rightly so. At the end of the day, my question is what needs to happen in the coming years so that access to mental health can reach the vulnerable sectors or those who cannot pay for such services?
Universal
fa-
health care.
universal healthcare, no? And do people in the vulnerable sector know about mental health in the first place? Broadly.
Sige, universal
Since
healthcare law yung
Mike.
sagot kasi it's really a law na 11223. And yun nga lang, medyo na admittedly no, na late ng konti yung package ng PhilHealth for mental health. Kasi nauna yung mental health package for inpatient, yung
Yes.
acute crisis. But recently lang, nitong nakaraan lang na October, nilaunch na ng PhilHealth yung outpatient benefit package for mental health. So that's the answer now. People who would like to seek consultation or services, be it of a general practitioner or mental health specialist, will be now covered with a certain amount if there are PhilHealth members. So it's now making mental health services more available and accessible to all. Kasi there's no need to worry about payment as
Yes.
long as, syempre there are certain protocols or guidelines on how to avail it. Pero as much as possible, there are now available services free of charge because of the PhilHealth outpatient benefit.
And it's very important that we have that, no?
And children are covered by their parents.
Yes.
Yeah, as long as the institution is
PhilHealth
accredited. Yes. Yon. So there's a lot of things that need to happen. But in essence, universal healthcare. So the physician, the psychiatrist needs to be accredited, the institution needs to be accredited. So if it's going to be through these apps also need to get registered sa
Yes.
PhilHealth. And PhilHealth would have to put out guidelines on how they're going to register and regulate these apps.
Again, if these apps would be approved by the Department of Health, then it speeds up the process on the field. So it goes back to what I've said. Na the Department of Health should take the lead in all of this, as the health governing body of the Philippines. Yeah, that's a health. Yeah.
And we have one last question from the Zoom. What do you anticipate will be the most significant changes or challenges and opportunities for mental health practitioners over the next 5 to 10 years? Moving forward.
Kanya-kanya kami ng kanya-kanya kami ng Dr.
from
Reyes as an institution. Ako as on the combination of institution and public health. I think the most significant challenges or changes or opportunities would be now is many people are highlighting mental health because of the law. So gone are the days, meron pa rin namang stigma and discrimination, but definitely we are moving forward on really becoming more aware about mental health. So later on, makikita natin yung trend siguro na hindi na aabot na may sakit na kaagad yung isang individual kung magpapakonsulta siya. Kasi dahil sa kanyang literacy about mental health ay nape-prevent na yung mga ganung situation because he will be able now to identify what can he do at this early stage na nararamdaman niya to. So I think that's one. Another trend is siguro dadami din or that is wish list na dadami din yung mga mental health professional kasi nagkakaroon na nga ng realization or demand na marami na ang kokonti ang supply pero marami ang nangangailangan. So nakikita namin yan ngayon. Like for example, NCMH as a training institution, we used to be nung time natin Apons, 30 lang tayo na residents. Pero now, we are having at least 80 or 70 na residents. So doble. So eventually, if all of these training doctors would become specialists later on, definitely from 630 something per 100,000 population, maybe we can hit at least 100 1,000 man lang siguro eventually per 100,000 population. So yun, we're also, but the challenges of course is one is funding kasi the mental health law is a law but dun sa funding source nakalagay walang specific na guidelines saan kukunin ang funding, di ba? Yeah. Pangalawa din is parang syempre yung dynamic ng leadership and governance. This is a law but then LGUs, local government unit, would have different prioritization when it comes to what are the programs to be implemented at their area. So gusto din sana natin or siguro yun, isang malaking challenge is to change the perspective of our leaders investing on mental health? Kasi sabi natin, majority of Filipino politicians would be more on something that is tangible, building, school, hospital, something like that. Pero yung mga programs na hindi nakikita, hindi masyadong priority. So I think that is one of the opportunity or challenges that we would like to address later on.
If I may add also, no, you have mentioned early on that there are just few psychiatrists or what, no? So in relation to the impact first investors, no, could we tap those what companies who were able to get the 17 SDPs to come up with a training program or probably sponsor more scholarships or more advanced trainings in as far as the psychiatrists are concerned, so that there will be more, no? Because we are actually in a situation now that the mental health professionals are at its height, no? Talagang superstar na, kumbaga, no? If we are to exaggerate, and that's reality. So same is true with also the psychologists more than 2,000 lang. So I think these are some of the things, and with the apps that we have all over, then it would help, and together with the apps would be the facilities also, no. And I have mentioned this because a lot of our students would be asking after we do referrals, ma'am, saan ito, and so, and kung nasa province, pupunta ka na Manila or what, no? So it's too far. Parang ganon. So again, these are some challenges, no? In as far as school setting, that we could not do the therapeutic intervention, and that would be our limitation. So we do refer it to facilities who would be in a position to do it.
Yeah, it's happening right now, no? But in other profession, like nurses, wherein governors will shoulder the tuition fees and do scholarship programs for the nurses. In return, there's a return of service. They practice in the vicinity, province. So yeah, maybe we can do that in terms of going to med school and going to residency, for psychiatry. Now, ano ba yung tanong?
Challenges. Opportunities. Challenges
Yeah,
and
Dr.
opportunities.
Boncay has already enumerated the challenges and opportunities in terms of being the patient, because literate ka na nga eh, no? But the professionals also should be preparing also, no? If they know that they have these symptoms, they should be prepared now. The physician now should be prepared to address the number of patients that would come. No, the institution also. No, it's all about change. No, nothing is stagnant naman. No,
Yeah.
we should always embrace change. Dati nga, IQ lang ang pamantayan natin. Ngayon may EQ na. Ngayon may adversity quotient pa.
Yes.
Where dati yung teacher pagka naka-perfect si Apons, good job Apons. Ngayon bawal yun. Dapat ang pinupunan ng teacher is the process, not the outcome. Dapat sabihin niya kay Apons, you've exerted so much effort. Congratulations. No? Hindi dapat yung output na pumasa siya. No? So those are changes now. No? Ano na ba ngayon? Those who are 15-year-old are what? What generation?
Gen Zs. They're Gen Zs.
Gen
now.
Z ba o Alpha na?
Alpha
Alpha
na? Okay, I'm late.
So it carries a different trait, a different than millennials like me.
Yes, I believe you're still a millennial.
No, so ganon. We should be adaptable. No, we should. So in terms of challenges and opportunities, if we see a challenge, we overcome it. If we see an opportunity, we take it. No, that's it. No, and hopefully, in terms of mental health, it's very difficult, no, because you have to please a lot of people. No, we kept on saying that healthcare should not be politicized, but unfortunately, it is politicized. No, may running joke nga ako eh. Sabi ko, schizophrenia. You know schizophrenia? It affects 1% of the population. If we are 110 million, how many of us are schizophrenics in 1%?
It's around
1.1 million.
1.1 million.
Oh. NCMH, the largest psychiatric hospital, has a bed capacity of 4,200 only. Where are the rest, the 1.1 million? They're in the Senate and the Congress.
Or being political.
That's the running joke. Actually, that's the running joke only. It's my joke
You
only.
can say that again.
Yeah.
Another joke.
Yeah. So that's it. No, we try to do our best with the resources that we have. No, and thanks to you guys. No, that we are able to bring this out. No, hopefully the discussion would when I go back to NCMH, I can incorporate this in terms of the meetings in my exicom and my policy making, and probably opportunities. No, that can be.
Yes.
You know,
Is there way for us to have public-private partnerships?
yeah.
Okay.
So speaking of yung opportunities and challenges, in the financing space, there's actually a contraction of a lessening of the amount of money going into mental health, into the mental health space. But this is true not just for the mental health space, but in digital health in general, because there was such a tsunami of money coming into the digital health space during the pandemic. It's contracting now, predictably. One, because investors are becoming more discerning. So they're not just, okay, this is a COVID-19 intervention. Yes, let's fund it. Oh, okay, this is a mental health intervention. Good, let's fund it. So investors are becoming more discerning. And how are they becoming more discerning? By interacting with you. So an opportunity is to take advantage of that interest in your field and get in touch with investors. We're not as scary as I'm not scary. We're not scary, or we're not, because I always tell this to whenever I speak in MSIB, for example. If you only interact with the people you already know, you'll only know the people you already know, right? And in order for radical change to come, radical collaboration has to happen. You need to develop those professional friendships with people that are outside of your field. And if funding is something that's a crucial challenge for your field, then you need to get to know funders. You need to get to know finance people. You don't necessarily need to go get to know their field. You just need to get to know them and develop that professional friendship, that trust. Because even after the program has ended, even after presidents have changed, if the two of you or the three of you or the four of us, are friends, we trust each other and each other's judgment, the program can continue, right? Because there's trust in our abilities and our collaboration. So that's what I would like to happen. So is there an opportunity for public-private partnership? Yes, I'm waiting for it. So what I would like to see actually is for the government to de-risk a lot of the more risky investments. So for example, there's a lot of drug development or the omics research that Dr. Reyes mentioned. We'd like to get in on that, but the risk is really high, right? So if the government says, all right, I take 50%, you take 50%, that's a good deal to be the first in, right? So we would like, that's already happening in other industries, in agriculture, in manufacturing, where we have a lot of models for public-private partnerships, and the government's job is really to screen and to de-risk, because we trust the government. We trust the government to lead the way, as Dr. Reyes said. So when that happens, we can participate more eagerly, hindi lang in the startup stages or in the early seed stages.
And I think what one important aspect here is you mentioned the collaboration. So incorporating what we call bridging leadership, wherein it's not only the proponents who are actually taking ownership of the program, but involving everyone else who are part of the ecosystem or who can be of help of the ecosystem to be to have that co-ownership, enable for us to be able to co-create programs that will last beyond our our lifetime or mortality, being able to actually lay a very good foundation in terms of being a good foundation for others to be for others not to have the difficulty that we are having right now. And siguro one last question before na, kasi I think it's already almost 4 o'clock. Dr. Hines, there is one question with you. For you, no? Is your association open to collaboration with private organization to certify teachers to be mental health first responder coaches? May questions sa audience. Okay. Yes, Dr. Hines. Ayan, basahin ko po, Doktora. Is your association open?
Ito, higher please. No?
Ayan.
I'm looking at that. I'm not seeing it there. No? Is your association
Yan,
open
oo.
to private organization, certified teachers to be mental health first responder? Oh, yeah, of course, definitely. No? In fact, we are into that. Initially, no, because we are talking of the challenges and opportunities, the first thing that I'd want to say is number one is to increase mental health literacy between and among the members who are in the school setting. And more so, if you are a stakeholder coming from outside, then the more that would be able to accept them also, because we do believe that there are limited financial resources in the school setting. And so coming from the outside, then it's a welcome thing for us to do. So probably number one, to come up with capacity building to increase awareness between and among the teachers, between and among the staff, no, and of also the guidance, the guidance people or guidance worker in the school setting, together with the parents, no, is very important, and other stakeholders working in school setting. So more so, if a private entity would be coming in to have collaboration with us, then we would welcome them. Number one, probably in the development of screening tools. Number two, in capacity building to the level of school down to the parents and to the LGUs, no? Because we are also taking care of this. There is such thing as PTAC, Parent Teacher Association, and the community. So we'll be able to touch base also on the community in as far as mental health literacy. And we need funding for this. And this is where the private organization probably would come, in order for us to have a stronger force, especially in terms of the funding. And of course, the end, we would know that in the impact first investing, the essence of that is to change the life, of whoever the end users would be.
Thank you, Dr. Hines. We have one question from the audience. Yes, Anne.
Hi, yes, I'm Anne Silva. I'm the founder of Tanglao Mental Health. It's a consultancy firm where we work with companies and schools in creating preventive mental health programs for their employees. But also, I am a strategic consulting partner with a company that's working with schools, private schools more specifically. And what they do is they address one, and I'm sure Dr. Hines understands this, one of the most crucial aspects of guidance, which is career. And so we directly work with guidance professionals, and on that ground level, we see a lot of them facing some issues in terms of students' mental health. Primarily that, and I hate to be the devil's advocate here, not all laws are implemented by private schools, right? And when it comes to mental health concerns of students, they definitely see the concerns that the students have, whether it's self-harm, depressive issues, right? But they would usually say they either don't have the budget for it, for mental health initiatives. They would say probably they would just go to hiring or getting a resource speaker to do a 1 hour talk for them, and that would be it. Unfortunately, that's really what's happening on the ground. So my question now is, what would be the strategy for us to implore them or compel these private schools to implement mental health initiatives for their students? Do we have probably an accrediting body that could probably use certain accreditations, let's say, to compel them?
Very interesting question, Anna.
This is one reality on the ground, and specifically in school setting. And I'd agree with you saying that not all laws are implemented, no. But one strategy that we could probably have is if that school or chains of school would have an organization, then we could tap the leadership, no, of that organization. Say, for example, we have the private higher education, no, private higher education organization. We have also the Philippine Association of State Universities and Colleges, for that matter. If we would tap the present leadership and try, no, to make them understand that this is a mandate, if not a law, and this could be, it could trickle down from the leadership down to the level. In every school, there is what you call Student Affairs and Services Office. Student Affairs and Student Services Office. And this is the office who would implement all the mental health activities, both in public and private, in basic education and in higher education. So this would be the right office who could come up with the mechanism, starting off with a bigger organization wherein this organization would make it as one of their advocacy that all member schools in that organization should be able to make this mental health as their advocacy, and collectively, these members of this organization school would come up with a working mechanism that there should be some kind of needs assessment. From the needs assessment, they're going to come up with the mental health program. From the mental health program, they have to implement, they have to monitor, and then to evaluate it. So from the development to its execution, no, and up to the last, there should be a tool for that. No? So I think that's one, no, that we could do. And this is also being done now with the OH in as far as HLI is concerned. Healthy Learning Institutions in basic education, in higher education, and even in TESDA. And there is a monitoring tool for that. We are into it. We meet every other month. And no less than, if we are talking of DepEd, Dr. Galban was there. We were there. So that is one mechanism, because there is now, no, a tool for the HLI, which would be covering one of the areas, specifically in the mental health implementation. Yeah.
Doc KM.
I have a different take on that question. If the question is how do you incentivize the school, you increase demand by getting to the parents. The parents pay the tuition for the kids. So if you advocate through the parents, through parents' organizations, about the services that they should be receiving from the school, that might be a way to do that. In fact, there's a startup that does exactly that in Thailand, although they're not doing this for mental health specifically, but for sexual and reproductive health education in schools, right? I'm one of their advisors. So that's public and private, and the way that they did it is through the parents. Because when the parents demanded that their kids should be receiving this kind of education, these kinds of tools, screening and referral, and access to the following services, it was very effective. So you might try that.
Or to add din ano, I think this has to be brought to the council, Philippine Council for Mental Health, because the implementation of the law, the policy making, and the identifying services and the rest that has something to do with mental health has to come to the Philippine Council for Mental Health. I'm just wondering, sino nga ba yung magmo-monitor sa kanila? Kasi specifically for the workplace, government institutions would be under the monitoring of the Civil Service Commission. DOLE, on the other hand, would be implementing the workplace policy for mental health for the private institution. So, iniisip ko nga din, pag sa schools ba, DepEd din ba siya? Pero, Ma'am Dr. Hines mentioned kanina HLI, so naalala ko bigla during the discussion na, there is the Healthy Learning Institution that will be rolled out eventually to all schools, and I think the primary mover will be the Department of Health. Pero I think when it comes to mental health specifically, it should be the Philippine Council for Mental Health. Yeah.
Actually, when we work with schools, ang kadalasan pinakikinggan ng mga private schools are school admin organizations. Whether it's SEAP, PASCO, accrediting organizations talaga. Yun. That's why I was asking about how do we insert, into their accrediting system.
Yeah, you ask about that accrediting system. Actually, that's the dilemma. Even for hospitals, Department of Health, government hospitals, but do they have power with private hospitals? No? Ganun din yan. No? So, DepEd, may power sila sa government schools, public schools, but can they exert sa mga private schools, Kaya siguro I believe that the parents would, because they're paying for it, they should be demanding ganun din, That's the experience we have, during the COVID time. Department of Health demanded that all hospital, be COVID hospitals to allot COVID beds for 30% of their authorized bed capacity. Sino sumunod? Government hospitals lang. Private hospitals hindi. As long as that patient is paying, confined ka. So, ganun. It's very hard. But for licensing kasi, I guess all should pass to a government agency, whether it's DepEd, in terms of licensing. So the license to operate has a term of reference, that should be fulfilled. If that is already in place, provide mental health, and it's approved, and na-check na yan ng licensing body, then the school should be implementing it.
And siguro siguro to synthesize then, this is an area or point of collaboration, not just between policymakers, those in the professional organization, but it should also extend to the parents. The parents have the responsibility for their children, for them to get better health care, specifically better mental health care, and it's something that if we are able to really bound our resources together, we can force our schools, private, whether it may be in the private or public institutions, to implement these changes. Yes, these changes are very difficult. However, if we are able to compel them, if we have a collective voice, in terms of not just with advocacy, but in terms of really putting forth the agenda of equity, then we can have that school-based mental health program that really addresses the problems of our learners. Okay, I think in the interest of time, we've been so into the discussion, no. I would like to call on Dr. Elmer Soriano to do the forum synthesis, no. Okay, Dr. Elmer Soriano is also an AIM alumni. He is a graduate of the Masters in Development Management, and he is our partner from Civica Lab Development Academy. So he will provide us with a comprehensive synthesis of the forum's discussion.
Okay, thank you. Thank you, Apons. I don't know about comprehensive. I'll just be sharing my thoughts. No? So listening to the conversation, parang malinaw ga that it is an ecosystem. No? Ang daming players, public, private, hospitals, schools, teachers, parents. Parang there's so many elements in the ecosystem. And the question was, okay, how can the ecosystem work so that at the schools, maging highly functional yung mental health system. And I thought that, in general, we were talking about schools as spaces where students spend a lot of their time, and a subset of them need attention, whether screening, primary, secondary, tertiary care. Pero we have millions of Filipinos in schools, and therefore school-based mental health is an excellent setting to work on. But I thought, I would like to call our attention to our forum ngayon, because AIM is also a school. Diba? You are now in a classroom, and the students, sina Apples kasi they're students, they started a student initiative to bring together different stakeholders and understand the different parts of the ecosystem. And therefore, this afternoon, the classroom that we're in, and the Zoom room that we're in, became a space for reflection and understanding the big picture, and then hopefully trying as a school also, we will get to diagnose the problem and then find a way forward. Kasi trabaho rin yan ng schools, no? Schools are supposed to be equipping students to solve problems. Yeah. So yun lang yung thought ko at the top level, no? And then in the conversation, we talked about the different aspects. It's complex. It's a complex system. May clinical, may financing, public and investment, no? May regulations. There's the technology, which is the IT technology and the biotech. And then we had some futures thinking conversations. And then there's that item of culture-based mental health. No? Many of our tools come from the West, and ito ba yung hiyang sa Pinoy, or should we be working on more culture sensitive tools? No? To me, ang parang takeaway ko dito, after the magnitude, and this I think echoes yung point ni KM, no? The magnitude of the problem is big, di ba? Malaking pangangailangan. And the solution providers, the pool of practitioners in mental health currently is small, and then the technology is evolving. I think it's an excellent equation, an excellent setting for leadership. Kasi the few who think as integrators can be particularly influential. No? So congratulations to the team, and congratulations to the panelists. I think yung conversation ngayon will become material, especially if we put it out there online on YouTube, so that it can become reference for others who will take the work forward. No? So I think those who are thinking about this can be particularly influential, so that we can help more innovators and startups to get into the space para magkaroon ng pipeline of investable startups. And then also so I'm thinking we're holding this meeting physically in Makati. Now I imagine that there are hundreds of schools that teach psychology, nursing, guidance and counseling. I imagine that I hope that many other schools in the other cities will have similar conversations like this para umusad yung agenda nila at the local level. No? Yung not waiting for the guys in Manila to have their meeting and tell them what to do. Dapat at the local level, ayusin na nila yung kayang ayusin. No? And then I couldn't help but think and I don't know if I'm just projecting what but I get the impression that there's a need for a mental health innovation consortium or coalition. Parang ang impression ko, yung ganitong klaseng usapin, bihira mangyari na focusing deeply on mental health. And I also get the impression na kung walang magpatuloy nito, this will evaporate. No? Meaning, it could be 1 or 2 years, and may magkaka-forum lang ng ganito, but in between, walang nangyayari dahil hindi nagtahi-tahi. No? And I think that's the role, that's where the bridging leadership, as Apples mentioned, comes in. No? There's a need for the stakeholders to co-own and co-create a consortium so that magkaroon ng ongoing pipeline. No? Otherwise, by the year 2030, diba, baka lumala na yung problema natin, and yet kapos na kapos pa rin tayo ng innovations and startups and private sector service providers to fill the gap dahil hindi natin napahinog yung innovation consortium like this. Yun yung sinasabing radical collaboration. I think this should be the start of professional friendships. And I think, sina Apons kasi they're about to graduate. So my fear is that, paano pag nag-graduate na sila, mawawala na lang ba to? So I suggest that after you adjourn, you'll formally adjourn this, you'll still be in the classroom, mag-usap-usap na kayo kung ano yung next step para may next steps forward. Otherwise, bihira magsama-sama yung ganitong mix of stakeholders. No? You might as well decide on something that you can do within the next 2 months so that hindi masayang yung momentum from this afternoon. Yun lang. Thank you.
Thank you. Thank you, Doc Elmer. Before we end, we have a QR code. Can you? This is a post-event survey that we actually do here at AIM every after a forum is actually done. Just to give us a feedback. No? You can scan the QR code and then place your post-evaluation feedback. So, before to provide us the closing remarks, we are honored to present a video message from a distinguished member of our academic community here at the Asian Institute of Management, Professor Joey Camus. So Professor Camus serves as an academic program director of the Master of Science in Financial Technology and plays a crucial role as our capstone advisor. We eagerly anticipate this valuable insight and perspective to conclude our discussion.
Ladies and gentlemen, distinguished guests, educators, mental health professionals, advocates, and investors. As we come to a close of this vital forum on mental health for junior high school learners, I wish to express my heartfelt gratitude to each one of you and every one of you for your unwavering commitment to this cause. The discussions and insights shared here today have truly been enlightening, and I am profoundly encouraged by the unity of purpose that has been displayed. In an era where the well-being of our adolescent learners has become absolutely pivotal, the importance of the work we are collectively doing cannot be overstated. Our students, the future of our societies, deserve access to robust, and nurturing support systems for their mental health. Today, we've not only discussed innovative paths and strategies to sustain and scale mental health initiatives, but have also witnessed the unveiling of a remarkable capstone project on school-based mental health for junior high school learners. This project represents a beacon of hope, a roadmap towards a healthier, more resilient generation. It is a testament to the dedication and the hard work of our educators who have tirelessly advocated for the emotional well-being of the students. Our primary objective with this forum was to build a platform, one that unites stakeholders from various sectors, educators, mental health professionals, advocacy groups, and investors, including those who may consider joining us in the future. We recognize that to create a meaningful change, we must embrace a multi-sectoral approach. The challenges we face are multifaceted, and the solutions must be equally diverse and comprehensive. Our commitment today is not merely to share ideas, but to transform them into action. We are here to pledge our collective effort, resources, and knowledge towards advancing mental health initiatives in junior high schools. To ensure that this vital issue remains at the forefront of our educational system, it is incumbent upon us to join forces and to work tirelessly together. Closer to my heart, in our discussions today, the emphasis on impact-first investment was evident. It's essential for us to present investors, as well as those who might join us in the future, to understand the transformative power they hold. By concentrating on the profound impacts of their investment, they can significantly shape the future of our young learners. I challenge our investors and potential investors present here not only to seek financial returns, but to also seek the profound impact their contributions can make in the lives of our young leaders. In closing, I'd like to leave you with a powerful thought. Our junior high school learners are not just students, they're architects of our future. I urge our mental health professionals and advocates to approach investors with an open heart and mind, recognizing them as potential allies in effecting meaningful change. By nurturing the mental health and well-being, we are building a foundation for a better society, a brighter tomorrow, and a more resilient generation. We are all part of this crucial journey, and our collaborative efforts are the driving force behind this transformative endeavor. Let's leave this forum today not only with a deeper understanding of the issues surrounding mental health in our junior high schools, but with a resounding commitment to be agents of change.
Okay. Thank you very much, Prof. Joey. To award the certificates, may we call on Cash Maghirang and Miles Melia Competente and Ms. Nicole Cortez, one of the program team of the Masters in Development Management. So, Certificate of Appreciation is presented to Dr. Noel V. Reyes, Medical Center Chief of the National Center for Mental Health, in grateful recognition for your contribution as a keynote speaker at the Mental Health Forum, Safe Mind Role of Impact First Investing for Sustaining School-Based Mental Health Initiatives. Your expertise has illuminated the critical pathway towards sustainable mental health initiatives in the educational institution, given this 7th of November, 2023. For the panelists po, sabay-sabay ko na lang po kayo. Same text po. Certificate of Appreciation is presented to Dr. Adelaida Hines, President of the Philippine Guidance Counseling Association. Rodney Boncajes, Head of the Special Concerns Unit of the National Center for Mental Health. And Dr. Christine May Magtubo, Associate Health Lead of Ignite Impact Fund, for the valuable contribution during as a panelist for the role of Impact First Invest. Okay, thank you very much. Thank you very much, everyone, and have a great day. For those who participated online, thank you very much for attending our hybrid session. And we hope that you have learned and a lot during this conversation. Thank you and have a good day.